levels go up. When we have a case that needs doing, that we need to operate on. But really, it should be the opposite, because we don't bat an eyelid at a 6'2" phaco. We'll go in and do it, even though everything could go very, very wrong. Whereas with trauma, we're only trying to make it better. And so we've had the luxury of being able to see this talk beforehand. We're in for a great time. Just in terms of the format, Maria will collect any questions that you have. We'll make it interactive, so please feed through any questions that you have, type them up, and then we'll read them out as we go along. And over to you, Fasika. Thank you again.
Thank you so much. It's really an honor to be here. Thank you for the introduction. So I am a cornea specialist at the Wilmer Eye Institute, and I also happen to be the director of the Eye Trauma Center, and then I'm the ophthalmology residency program director. So a lot of the residents are involved in the trauma. So this is why I sort of got into that role. So again, it's an honor to be here, and I'll just start by going into our talk. As we mentioned, we do want to make it interactive, so please put your questions in the chat. And then we'll stop and take them as they come. And I don't have any financial disclosures. And so basically I want to begin by discussing the Birmingham eye trauma terminology briefly, as that's very important, and then review basic principles in the management of open globe injuries and hyphemas. And then we're going to discuss some anterior segment reconstruction techniques following trauma, focusing on iris injuries, as well as traumatic cataract and traumatic aphakia. So the reason I wanted to bring this up is because I hear the residents all the time discussing that we have a ruptured globe. So I wanted to discuss this terminology. And so when we say ruptured globe, that's actually incorrect. So open globes a ruptured globe is a type of open globe injury, but it's either a laceration or a rupture. And when we talk about lacerations, they can be penetrating, which are most common, perforating when there's an object that goes through and through, or there can be a retained intraocular foreign body, which is really a type of penetrating injury, but because it has sort of, IOFBs have a special sort of their own course, it's labeled differently. And then so again, rupture is when there's when the eyes hit with sufficient velocity that it causes a rupture of the eye wall, which I'll show you in my next slide. And when we talk about closed globe injuries, they're divided into contusions, and we'll go over hyphemas and other types of blunt injuries, as well as lamellar lacerations, where there's partial thickness but not full thickness injury into the eye wall. And so when we look at a rupture, again, the eye is hit with the object of sufficient velocity to cause rupture, and the most common places are depicted here. So one would be the limbus. These are areas of weakness. One would be under the rectus muscles, and then the third would be at the optic nerve. And as we know, ruptures have worse prognosis than penetrating injuries. And when we talk about open globe injuries, the classification scheme we use is by the zone of involvement. So this is just to briefly review that. So zone 1 is involving the cornea, and then 5 millimeters into the anterior sclera would be a zone 2 injury, and then posterior to the 5 millimeters is zone 3 injuries. And as we know, the worse zone, the more posterior, the worse prognosis. And you know, for the residents in the audience, I remember starting my residency and being terrified of missing an open globe. So sometimes it's more obvious than others, but classically a peak pupil, if there's 360 degrees of hemorrhagic hemosis, you have to sort of have a high index of suspicion. If there's asymmetrically low IOP, that could be a sign, although there are open globe injuries with normal IOP, any shallowing of the anterior chamber, and some focal transillumination defects of the iris or lens, as sometimes the corneal entry wound can be subtle. So again, obviously this patient on the right-hand side walked into the emergency room, so that was pretty obvious. But on the second case, you can see there's an intraocular foreign body that's embedded into the lens. Sometimes you'll need to do gonioscopy if you're worried about an IOFB in the angle. And you know, I think it's important for emergency room doctors to remember that if the mechanism of injury is suspicious, to have a low index of suspicion for obtaining a CT scan to look for a foreign body, because I've certainly been involved in reviewing medical legal reviews where a foreign body was missed. And again, as we know for metallic foreign bodies, the CT scan is the preferred modality. And then the Seidel test, which you know, is, as again for the beginning residents, is very important to do. Basically, you take a fluorescein strip, and then you would get a new bottle of anesthetic, proparacaine or tetracaine, and then paint the surface. And some gentle pressure will sometimes show a gush of aqueous, or sometimes even as they blink, you can see the aqueous diluting the fluorescein. So this was a patient I saw when I was chief resident, and you can see here the gush. So shielding the eyes, sometimes our emergency room colleagues forget, but shielding the eye is very important. Most centers will give intravenous antibiotics, which is indicated, and then primary repair as soon as possible. The exact timing of the primary repair is a little bit controversial, but you know, I think as soon as possible to reduce infectious risk is important. And so for corneal injuries, you know, we use 10-0 nylon, and then for the limbus, classically we say 9-0 nylon, and for the sclera, classically 8-0 nylon. But I find that you can use 9-0 nylon in the sclera just fine. And then as I discussed later on in the talk, we'll discuss reconstruction techniques. So for iris repair, you can use either 9-0 or 10-0 Prolene. And then I'll briefly discuss scleral suturing of lenses in the cases of traumatic dislocation that resulting in necessitating suturing. And basically, you can use Prolene for that. And that's been used a lot in the past, but Gore-Tex is something that's gaining popularity. So I do want to, for the residents, discuss some principles of corneal suturing, as it's very important. And I can tell you that when I suture with my residents, a lot of times it's very hard to get a resident to enter perpendicularly to the cornea, and I'll show that in my next slide. But you want to enter and exit perpendicular to the corneal surface so you can get to the right depth. And the proper depth classically is 90%. Dr. Farron Kuhn, who is sort of a very big figure in ocular trauma, always says that 100% is also okay. And so that's shown here in figure B. And the reason that he says that is because he thinks it seals the aqueous, and so that you get faster clearing of the cornea when you go 100%. So I think either 90 or 100% is fine. He's a retina surgeon, so is interested in the cornea clearing as quick as possible. You want to make sure that the suture is equidistant on both sides, and they're radial. And then lastly, to bury all sutures. So we've seen many times where patients come with unburied sutures, and it causes a lot of foreign body sensation. So whether I'm doing corneal or even scleral suturing, I'll always try to bury it.
Fasika,
and so this is what yeah.
You just a point, please. Many surgeons will discuss the full thickness introducing infection as you're going through, and I get the rationale you've described. Could you just explain a little bit more about that and your thoughts, please?
Yeah, absolutely. So certainly that's what I learned when I was in residency, in terms of if you go full thickness, that is an increased infection risk. But what Dr. Kuhn strongly argues is that when you're removing the stitch is when that infection risk is there. So basically, you know, removing it by applying betadine in a sterile technique is what he says. But he feels strongly that that the 100% is superior rather than the 90%. But yes, I think when you're removing the stitch, you're certainly rotating the knot through the anterior chamber. So make sure to put the betadine before, and wait a minute.
Thank you.
A great question.
Thank you.
And I think also one other thing about the 100% is I think for the 90% suture. So in our at Wilmer, basically our second year residents are the ones who begin closing open globe injury. So I do think that sometimes for the resident to exactly gauge the 90%, exactly 90% is difficult. So I think that's maybe another advantage of going full thickness. At least they won't be too shallow, which is common. And the perpendicular entry is what I mentioned here. So I rarely see residents actually going 90%, just because it's awkward and you don't see the needle, the tip of it. So I think that's something important to remember, that you should go 90% because that allows you to get to the proper depth here. And then burying the knots again, just for the non-cornea surgeons in the group, because again, I've seen many come to the ED with unburied sutures, let's say after unplanned complicated cataract surgery, and they come because of foreign body sensation. So you want to make sure they're comfortable. And then just in terms of keeping the wound astigmatically neutral, what you want to do is if you have a long laceration that spans the entire cornea like this, you want to keep the peripheral sutures more longer than the central sutures, and that will give you this. That'll avoid the flattening here, as if you put short sutures in the periphery.
Gurjeet, it's Imran Masood. Can I ask a question?
Go for it, Imran.
Very nice talk. I've got a question about the type of knot that you use. I've in repairing these types of injuries, I've often used a triple one or a quadruple one knot, simply because you can gauge the tension because you're using a sliding element to the knot initially, but also you end up with a knot that's far easier to rotate. So can you just comment on the type of knot that you throw in these cases?
So great question, another great question. So basically the 3-1-1 knot is what I use. So, and then I do lock it before tying the last one. So, and then like you said, once you lock it, it makes for a nice compact knot, so it'll bury easily. And it's, I think, the strongest knot. And then a lot of people also use the dangle or the slip knot, where it's a 1 and a 1-1 on top of that, and they adjust the tension throughout the case. So I think it really depends on the severity of the laceration, because in the beginning, if there's no, I don't think I would use the slip knot if you need to get some structural integrity and it's spanning the entire cornea. Where if it's a small laceration, you can use the slip or dangle knot, and then at the very end adjust all the tension. So it's a good point, but I think there's a 3-1-1 knot or a dangle knot is what is most commonly used.
Fasika, we
Yes.
easily say that knots aren't buried and we comment on them or criticize them. Have you got any advice about how to bury a knot? I was hearing old bosses tell me it's a saccade, not a smooth pursuit.
Yes. So basically, here it is. Okay. So for number 1, you want to have your, you want to be parallel, holding the needle driver parallel. And then also it's very important to have the right tension knot. So if it's too loose or too tight, that's a problem, because if it's too loose, it won't bury. And if it's too tight, when you go to bury it, it may snap. But you can see here the motion here and the needle driver sort of parallel. And so as you mentioned, it's a smooth movement. And even when I'm suturing, let's say I'm doing a scleral tunnel for whatever reason, and I'm going to put some sutures in the I'll still bury those knots. So I think if it's the right tension, you really should be able to bury these knots.
And Fasika, is it a myth that if you put a little bit of HPMC on top of the knot, it lubricates it through, or am I just wasting my time?
No, I also, especially like if I'm doing corneal transplants, and if I have any difficulty, I'll just put a little bit of the viscoelastic on top, and it does sometimes help.
Thank you.
I think that's a good question. So when when the resident's done halfway through a corneal transplant, I'll start to bury the knots, and then that'll help me, assess the tension, because you'll see again, if it's a tight knot, it's hard to bury, and sometimes it'll just snap, and if it's loose, it's hard to bury too. So, but if it's the right tension, then sometimes I'll just add a little bit of viscoelastic to provide some lubrication. Okay, great. And then so when we're attacking so you want to have a plan when you're going to the surgery. So depending on the type of wound there is, then again, I try to think of the plan ahead of time with the residents. So for this one, you can see it spans the entire cornea, and then you traditionally you say to start on the outside and then go in. So you can see the order here, and I mentioned how to keep it astigmatically neutral. If it involves the limbus or angles, you want to approximate that first, as restoring the anatomy is most important here. And then if it's like if it's a straight wound, then you can do the bisecting it. So you put the first one 50% and then bisect. So these are some different types of wounds. This is one that we saw, which was a complex stellate wound. So you can see you would want to approximate the angles first, but these can be tricky. This was a patient who I was consulted on after the initial repair. You could see they did a nice job repairing the cornea, and I was consulted for a possible corneal transplant. The patient was 6 years old. So I think, Gurjeet, you said you have a case of a pediatric open globe at the end, but for kids, basically, you can take out the sutures much faster. So you can see basically at 1 month, we take the child back to, basically at 1 month, we take the child under anesthesia and remove all the stitches, and you can see how the scarring was decreased dramatically. So I think kids, they heal much faster. In adults, I'll usually wait at least 6 weeks before removing any stitches. But in kids, again, you can just take them all out at once. We do the same thing for pediatric corneal transplants. Basically, you can remove them much earlier than you would in an adult. So yeah, sure.
Can I just get to that point whilst you've nicely illustrated it here? So the last few penetrating injuries I've done are on kids, because it seems that the rest of the team always take the surgery as adults.
Yeah.
We had two examples that I wanted to discuss. One was an 8-year-old who quite clearly had a knife to penetrated fully into the eye, and as a consequence, we knew he was going to have secondary repair. So as a consequence, I used a nylon suture and left it at that, fully knowing that he was going back to theatre. The other case was was last night, actually. A 3-year-old, Ahmed and Maria were involved as well, and Ava, if she's in the audience. Anyhow, patients' parents were doctors, and then they were discussing Vicryl versus nylon. And I think it'd be good just to get your thoughts now in a patient who's got just a corneal lac. The other one was basically limbal to limbal. Here we've got a small corneal lac. Essentially, we're going to suture the paracentesis and where the lac is. What's your consideration for Vicryl versus nylon in that situation?
Yeah, great question. And I think, I think you hit it on the nail with the fact that if they're going to need another procedure, for example, like you said in your first case where you knew they were going to have a second case of anesthesia, then you can certainly use the nylon. I mean, in general, I think I like nylon better because it's sort of less inflammatory and better tolerated. But in order to spare the second child anesthesia, I wouldn't hesitate to use it, either Vicryl or Sinuso. So I think if it's a small laceration and you can examine the child well and you're sure they're not going to need another EUA, then certainly I would use an absorbable suture. And a lot of times in the eyelid lacerations too, same thing. You can use some absorbable suture to try to avoid anesthesia in children, because I mean there is some evidence that multiple repeated general anesthesias can sort of affect learning and so forth. So. But in general, for adults, I like sometimes I like nylon better in adults because I think it's sort of less inflammatory. So sometimes my residents at the end of cataract surgery will be happy to do the Vicryl, but I feel like the nylon is better in those cases if it's a cooperative adult or yeah.
Totally agree.
Okay, so then I'm going to briefly talk about how to manage the iris in these cases, because sometimes it can be difficult since the iris wants to prolapse out of the full thickness wound. And so one principle is to, you may be tempted to put a lot of viscoelastic in the eye, but you actually want to do the minimal amount of viscoelastic and Even Dr. Kuhn says even no viscoelastic sometimes. And so because the reason is, of course, if you put too much, it's going to cause a pressure gradient and there'll be more prolapse. And then also it can be hard as the iris is prolapsing to avoid incarcerating the iris into your suture. So you want to be careful to do that. And I'll show a brief video. And, you know, in general, we can use the iris for, we can reconstruct it sometimes. So you don't want to cut it unless absolutely necessary.
Fasika, could you make a comment on, let's say you've got a corneal laceration and you've got iris plugging the wound, and let's say iris has come out of the wound. Could you just comment on the development of a membrane and how you would peel that membrane off, how typically you would do it, and also preserving tissue whilst doing so?
Exactly, especially in cases where the patient may, you know, wait before coming in. And we've certainly had the cases where the iris has plugged the wound and the patient won't present, you know, even after a couple of days. So in that case, you would be worried about epithelialization of the iris, and obviously want to avoid epithelial ingrowth. So basically, I'll usually take a Wexel sponge first and try to find an edge, and then gently take some tying forceps and peel. And in that case, like you said, you do want to remove the epithelium before repositing it to reduce the risk of epi ingrowth.
Yeah, I agree. I love using the tying forceps to peel it off. But...
Yeah, absolutely. So in the next case, you can see this was actually a police officer who was at the shooting range just practicing, and then unfortunately was hit in the eye with a stray bullet. So you can see my resident is putting a little bit of viscoelastic in there and then using the iris sweep to gently reposit the iris. Now, unfortunately, this was a small limbo laceration, but you know, with larger lacerations certainly, and even in this one, you'll see that the iris is trying to prolapse back out of the wound. So using 9.0 nylon here, you can see you can use the sweep or your tying or your 0.12s to sort of reposit the iris while you're taking the bite, again making sure not to incarcerate it. And then once you have a couple of sutures in, you can use your iris sweep again to make sure that it's free, as shown here. So, and you can see here just closing the peritomy. So he subsequently did develop a traumatic cataract, which we removed, and he's doing really well. He's 6/6. So again, you want to try to minimize the damage to the iris there. And so this, I wanted to briefly discuss the ocular trauma score, which some of you may have heard of. And again, this came out of the Birmingham eye trauma registry. And so you can see here, basically, well, just overall, you know, poor prognosis is related to poor preoperative vision, if there's a blunt mechanism or rupture, as I discussed, if there's a relative afferent pupillary defect or retinal detachment initially, as well as a more posterior location, we know that these are poor prognostic factors. But this ocular trauma score was developed to try to provide prognostic information for patients. So you can see here what the initial vision, they get a raw point value for the initial vision, and then if they have any of the factors that we mentioned, then they lose points. So then you basically, you can see the trauma score here goes from 1 to 5. So for example, if their score is higher, then the chance that their there'll be NLP at 6 months is 0. So this is how you use it. This is how, if you want to be really precise in terms of counseling the patient, you can certainly use this. All right, any final questions about open globe injuries before we move on to closed globe injuries?
Not so far, not any, they have not made any other one yet.
Fasika, I was just gonna say one thing, which is a tip. This is myself, I'm rubbish with numbers. So I always remember it as 10987. In terms of the suture diameter that I use from the middle to the outside. And
for the cornea and the limbus.
Yeah.
And the sclera.
Then I never have to ask, because I can remember 10987, I think. The other question was, you know, when you do the anterior sclera with a non-absorbable, do you ever get hedgehogging, or you rarely see that with sutures protruding through?
Yeah, that's with the, you mean with the nylon?
Yeah.
Yeah, so that's a good question, because when you're taking the scleral sutures, like you said, usually I'll I'll go full thickness for the scleral sutures, because like you said, if you try to go partial thickness for the sclera and then have to retake the bite, or because it's not too deep, then you can get, like you said, you'll see your suture through the sclera. So usually for the scleral bites, I'll go pretty much full thickness.
Okay, very good, thanks.
And then again, when you remove the sutures, well, with scleral sutures, you're not going to remove them. They'll stay there until the nylon, it should stay there for forever. But I do bury them again, because even if it's covered by the conjunctiva, I think it's more comfortable if you can bury them.
Thanks.
All right. So we're going to move on to closed globe injuries. So we have, we discussed the lamellar laceration, which I'm not going to discuss further, but we'll move on to contusions. And hyphema is something that we see pretty commonly, although rare overall, but I think in trauma centers, you'll see that commonly. And then we'll talk about iris injuries. I won't talk about the cyclodialysis cleft, but with that, a patient could present with low pressure. So you always want to go after you want to do gonioscopy if they have a low pressure, and sometimes they can spontaneously close. And then we'll briefly talk about lens injuries. So in terms of hyphema, it's like trauma in general, it's more common in males, and it's mostly a result of sports injuries. It can also be secondary to assault, motor vehicle accidents, but blunt trauma is by far the most common cause, although you can find it concomitantly with open globe injuries, and the bleeding is from usually the ciliary body vessels. So this is a patient who came to our trauma center who was hit by a baseball. Initially, the pressure was 44. In addition to the injury, also had an orbital floor fracture. So this is when the patient comes in for follow-up. So you can see that the patient wasn't compliant with the recommendations of sleeping with the head upright because the hyphema is layered on the side. So in terms of the grading system for hyphemas, I mean, you can measure it in millimeters as a way to follow it, or you can use the grading system where grade 4 is an 8-ball hyphema, and grade 3 is more than half but less than an 8-ball hyphema. Grade 2 is 1/3 to 1/2, and then and grade 1 is less than 1/3. So the reason it's important to sort of measure the height is because you can have rebleeding, which is associated with poor prognosis. So you want to know if the patient had a rebleed. Complications of hyphema include corneal blood staining. And then I mentioned rebleeding, which is also associated with a higher incidence of glaucoma and corneal blood staining. So, and then as we know that what we have to worry about in these patients is the elevated intraocular pressure, which happens in 1/3 of patients. Actually, we just reviewed our results at Wilmer, and it happened in 40% of patients. So it's high risk. And then with the high pressure, they can get optic nerve damage, and especially in patients with sickle cell trait or disease, they can undergo damage at lower pressures. So if you see a patient with African or Mediterranean background and with a hyphema, then you should check a sickle cell prep. And so I remember being a resident and sort of thinking a pressure of 26 wasn't that bad, but in the sickle cell patient, basically you would have a much lower threshold in terms of what's a high pressure. And these patients are at risk for angle recession, so which is when they have a tear between the longitudinal and circular muscles of the ciliary muscle. And so, remember too that these patients need lifelong exams even after the hyphema clears to look for angle recession, as it's a risk factor for glaucoma. And then, so there's a Cochrane review on the management of hyphema, but basically the role of, we do use corticosteroids and cycloplegic, but in the Cochrane review, the numbers were too small to show any clear benefit, but I think we use it. And then I mentioned the risks of a high IOP, so you want to closely observe these patients, and whether it be every other day or daily, and then tell the patient to sleep with the head of the bed up. And then we don't use these aminocaproic acid, and really we don't use it at all, because of the risk of side effects, although it does reduce the risk of rebleed.
Hi, Simran Masood. Can I start with a quick question about that? Because it's on the issue of use of corticosteroids. What I've seen quite a lot is that patients who have hyphemas automatically get put on corticosteroids, and then their pressure goes up because of a steroid response. So they may not have had high pressure when they presented, and you see this particularly in younger patients, particularly in children who are more prone to a steroid response anyway. So I sometimes think that we need to be, why are we giving patients corticosteroids? That's my question. And also, even the cycloplegics, what's the rationale for giving cycloplegics? Because, when I was a resident, I was always told, well, it's to prevent rebleeding and things like that. But actually, the reality is that the bleeding doesn't occur from the iris, and immobilizing the iris makes no difference to re-hemorrhage rate. So, what are we doing when we're giving people steroids and cycloplegics?
Yes, I think that's a great question. And like I said, the Cochrane review actually didn't show a benefit because the numbers were too small. We actually did a preferred practice pattern survey of trauma centers to ask about hypema management, just because there's no trial that can give us the answer. And the large majority did use corticosteroids. But I think your point is excellent. And for us, for example, we'll use it initially. But I think your point about not using prolonged corticosteroids is very important, because sometimes it can take weeks and weeks for the hypema to resolve. So usually, I'll use it for a short period of time and stop it. And it's not like uveitis where, I tell the residents you're not going to be tapering it very slowly, so I just use it in the acute period. But, your point is well taken in that what is the evidence and what, so I think that's something that's a question in trauma that we can sort of look for answers for. And at least the cycloplegic, is harmless unless they get it in the other eye, and that can be uncomfortable. But I think you're right about the potential for a steroid response. And I think the role with the steroids, even after open globe injuries, like I tell the residents, you have to be very aware of how long you're using the steroids for. Like I saw one the other day who had been on steroids for several months and did have a steroid response. So I think your point about the steroid response and being careful, in particular in children, is well taken. And also, I mean, in traumatic iritis, we use steroids for a brief amount of time. And in microhyphema, we often teach the residents to give some steroids, mostly for thinking that it helps whatever component of inflammation there is. So, and then for the washout, the indications for the washout, it's in the literature, and it's a little bit older, but basically if they have very high pressures, or if they have moderately elevated pressures for a longer period of time, any type of corneal staining is an indication for washout. And then again, sort of an 8-ball, a very large hyphema for a prolonged period of time is also indication. And we mentioned, as I mentioned, I trained at Wilmer, so Dr. Goldberg did a lot of these studies in sickle cell patients, and basically the indication for sickle cell patients is more than 24, pressure higher than 24 for more than 24 hours, or repeated IOP spikes. And this is just a picture showing how we do a washout. So I like to use sort of the bimanual irrigation and aspiration versus a Simcoe. I mean, you could use a Simcoe as well, but I like the closed, smaller wound here. And you can see this. Mm-hmm.
Quick question. The clots that you encounter in the eye, could you just make a comment about, chasing the clots, aggressive chasing the clots?
Yeah, I certainly don't do the aggressive chasing, like you said. So I try to, so you can see in this case, well, actually, in this case, it was an open globe combined with a hypophemal washout, and there's a traumatic cataract underneath. But yes, if it's been 5 or more days, there certainly can be clotting. So you can use, I like the bimanual because you can use the 2 instruments to sort of feed it a little bit. And then you can also use an anterior vitrector to wash out. But I think your point about not aggressively chasing a clot, because there is a lens behind there. And so you want to be sure that you're, number one, maintaining the stability of the anterior chamber and not being too aggressive. Otherwise, you can get a traumatic cataract from your washout. All right, so then we're moving on to anterior segment injuries. And so basically you can have, I like this figure here, which is sort of a classic figure that in the traumatic glaucoma. So here you can get, the first one is you can just see radial sphincter tears, and that can cause dilation. You can have an iridodialysis, which is disinsertion from the base here. You could have angle recession, which I discussed was the tearing between the ciliary and longitudinal muscle. And then you can have a cyclodialysis cleft leading to a low pressure. And then TM tears, and then you can have, and I'll discuss this later, lead subluxation and dislocation, and trauma is actually the most common cause. And then you can get traumatic retinal dialysis as well from tears. So this is a case of that I saw when I was a chief resident as well, where you see there's a sphincter tear here, and then there's also a superior iridialysis and also a traumatic cataract. And this was from a blunt trauma. In this case, you can see the iris is sort of diffusely, there's diffuse atrophy, and you can see the prior corneal wound here. And so for traumatic mydriasis, you can repair it if the patient's symptomatic. And I usually like to do it at the time of cataract surgery. Otherwise, I'll show you the needles that we use to repair the iris, and they are long needles. So, you know, there is some risk of lens damage if you're doing it on its own. And then you want to, when you do the pupilloplasties, you want to do the an internal sliding knot, like the Seepster knot, which I'll show here. So when you're doing the Seepster knot here, so this is a very nice laceration where there's just a focal defect, so it's amenable to pupilloplasty. So the first step is to make a paracentesis, and then you're going to take a long, and you can see it here. You want to take a long CTC needle, and you can use 9-0 or 10-0 proline for the iris. And then the first step is to put the needle through this paracentesis. You want to make sure you're not catching any tissue and that you're free in the paracentesis. Otherwise, when you go to tie, you can realize that you're caught on the corneal tissue. The needles are very sharp. And so once you go use the CTC needle and you cross both ends of the iris and come out on the other side at the limbus, the needle now is on this side. And then to do the Seepster knot, what you do is you externalize a loop through that same paracentesis. So you can see here's the free end, and here's the loop that you've externalized. And then you tie it like this, and then you pull both sides, and then you get this internal knot. So it's very elegant. And then basically then you would repeat the same thing, where you externalize the loop through the paracentesis, and then tie another loop. And again, pull both ends, and then you'll get the internal knot. And this technique is basically in contrast to the mechanical suture, where you're tying it externally. And for this technique, what you would need is some intraocular scissors, like some 25 or 23 gauge retinal scissors, and then you would cut it inside the eye through your paracentesis. And often you'll get a keyhole appearance once you do your first pass, so you can do another pass here to get rid of that.
Fasika, can I ask you, there are 3 questions from the audience. First one is,
great.
First one is if you use RTPA for the management of hyphema. That would be the first one.
If I use, I'm sorry, I didn't hear what the medication was.
Yeah, tissue plasminogen activator.
Yeah, so we don't use it. So, you know, it does reduce the risk of rebleed, but I think because of the systemic side effects of using these agents, basically, we don't really use it in the US anymore. I don't know about in the UK.
Mm. And well, second question is do you have at the Johns Hopkins like a proper unit that manages ocular trauma? It's like, for example, do all the traumas go to a specific team, or is it usually, well, I guess that it's usually managed by the person who is on call, and then those patients are referred, I don't know.
Yeah.
Yeah.
Yes, good question. So we are a designated eye trauma center. So we have somebody in-house who's a resident 24/7, and then we do have a chief who's a fellowship, usually a fellowship trained specialist, who then does the trauma case with the resident when they come in. Mm-hmm. So we used to have our own emergency department, and now we integrated into the main emergency room. So although we don't have an eye-specific emergency department, we do have sort of somebody, an ophthalmologist in-house 24/7. And there are some criteria that we need to fulfill to maintain our eye trauma center designation, like having 24/7 coverage, appropriate subspecialists, the ability to operate at any time of the night, for example, for intraocular foreign bodies or endophthalmitis.
Mm-hmm. Mm-hmm. Okay, thank you. That's very useful. Thanks.
Just a question about TPA. I don't use TPA. Do you?
Who are you asking?
You.
Yeah, that's what I was going to ask Fasika about. So we use it in the back of the eye for some indications. And the reason that you stopped using in the US, was it because of a problem or just sort of prophylactic stop?
Yeah, you know, ever since, yeah, you know, we haven't used it for many years now. Like even when I was doing my training, we didn't use the so the topical or oral aminocaproic acid, but the TPA, as you said, you can use and select, you know, locally in the eye in select cases. But you know, and like you said, you use it for retinal conditions.
Yeah, some bleeds, some use it for a suprachoroidal. But you mentioned about the systemic side effects.
Of the aminocaproic acid, so they looked at topical and oral, and so in terms of, yeah, the oral I think definitely we don't use. And ever since I mean, I did my residency starting in 2008, and we were not using topical aminocaproic acid. And then in our survey, nobody in the US was using it. So that's a good question about in terms of TPA. I think there was one case we used TPA, and well, I heard of the TPA being used anecdotally, but we don't routinely use it. And and so I think it showed that the risk of rebleed is lower. In the Cochrane review, it did show that there was a reduction in the risk of rebleed, but you know, I don't know how in your setting how common that is. I mean, in the literature, the rate of rebleed has been described to be as high as 20%. But when we reviewed our 100+ cases over the last several years, we found that the rate of rebleed was actually 5% or less. So it is low. But maybe you could think about the TPA in refractory cases potentially. But normally, I think the washout pretty much works in terms of lowering the pressure. I think sometimes it does have to be combined with the glaucoma surgery in order to get a sustained, but we don't generally do like a trabeculectomy at the same time or two. We usually will try the washout and see.
Yeah, agreed. Thanks.
All right, great questions. All right, so moving on to the iris injuries. So I went over the seeps or not, and so I'm just going to show you what this would be like. So I mentioned that the needle is long, and so in this case the cataract is already out. But if you're doing this in a phakic patient, you would want to be extra careful. So basically, in this case, this is what this patient had significant trauma and then had a traumatic cataract, and you can see this is at the end of the cataract surgery with Myocal injected, so there's just diffuse traumatic dilation. So you can see here, you can use some max grips forceps to hold the iris, and then when you come out, you want to come out at the limbus. You don't want to come out 1 to 2 millimeters behind, because that makes fishing of the suture very difficult. So then, so we're externalizing the loop here, which you could see better in my cartoon than what you can see here. But then once you tie the loop, and you'll pull on both sides. You can see here, this is putting it on stretch, so you're getting a little bit of an iridodylosis there, so you want to be very careful. And then, as I mentioned, you can get this keyhole effect. So if you want, you could do another suture here, but at least this reduced the pupil size for the patient and made them a little bit less symptomatic. Okay, so then this is another example of one I was involved in, where in this patient, basically you could see what the pupil looked like before, and then we did the seeps or not with the pupilloplasty, so at least reduced the light somewhat. For iridodylosis repairs, and Gurjeet, I think you said you have a video of this as well, but basically if it's under the lid and small and superior, then the patient is often fine, but sometimes they can be large and inferior in location, and they can be symptomatic, causing polychoria, glare, photophobia. So you can surgically repair these. So and then there's basically 2 ways to do it. One is with a scleral flap like this. So basically, you would do a peritomy and then do a scleral flap, and then you would make a paracentesis opposite to the area of the iridodylosis. And then what you would do is use a long double-armed Prolene suture with those long needles that I showed you. And then you could use like a 27 gauge needle or a 25 gauge needle, and you would put it here, and then you would dock the Prolene suture, and then both sides. These are the 2 long needles here, and then basically then you're tacking back the iris back to the root here. So then you can see here that there are 3 done in this cartoon, and then you would just tie it under the flap and then put the flap down. you could either suture the flap down or put to-seal glue to close it, and then close the peritomy. So that's one way. And then another way is to do a Hoffman pocket. And basically in the Hoffman pocket, you would make a corneal incision and dissect backwards. And then the advantage of the Hoffman pocket is that you avoid doing a peritomy, basically. So this is an example of a patient that I did with my resident. So this basically, there's a traumatic cataract. And so I think the first step should be to remove the cataract in retrospect. In this case, we did the iridodylis repair first, and the needle did end up scratching the lens in the periphery. So that's why, again, you have to be really careful. Fortunately, we were still able to complete the rexus and everything, but the long needle can be scary. So you can see in this case, basically we do the Hoffman pocket. So what I'm doing is, first we're making the paracentesis, and we're going to use trypan blue to stain the anterior capsule in the case of the traumatic, to remove the traumatic cataract. And then in this case, you could either put like one iris hook and then do the phaco and then do the iridodylis repair. But in this case, again, I did the iridodylis repair first. This is just a clear corneal wound for the phaco incision. And then you'll see, basically I'm marking carefully where the pockets for my, for the iridodylis repair will be with the Hoffman pocket. And so you can see you take a crescent blade and then you're going to dissect backwards. And this does take sometimes moving the microscope to get to the right angles, but you can see here the Hoffman pocket is being created with the crescent blade. I mean, I think, making it a little bit bigger than the crescent so you can actually maneuver it is good. And this is what I was instructing my resident to do. And then basically, then you'll do the same thing as I showed in the other picture, except it'll be under the Hoffman pocket, and then you externalize the sutures through the pocket. So you can see the pupil is drawn a little bit this way, but the iridodylis is fixed. So this is what it looked like at the end. All right, and then so for traumatic aniridia, sometimes you can just get defeated, just the iris is gone from the trauma. So this is a case where I had to do a sutured IOL, and you can see the whole IOL because the patient is fully dilated. So this was another patient that I saw who had who had 3/4 of the iris disinserted here. You can also see he initially presented with a hypema and high pressure and did have a tube shunt here. But then after the tube shunt, he was 20/20 and came back and was wondering what to do for the iris. So I just want to briefly mention the artificial iris because in patients with traumatic aniridia that can be an option. So I'm just going to show a brief video of that.
Fasika?
Mm-hmm.
Yeah. I just want. I like the video here. The way you, I saw it the other day. Just the way you actually injected it in. I thought that was really elegant and nicely unfurled. Yeah,
it goes in a B cartridge here. So for us, I mean, this was FDA approved in the US about 1.5 years ago, and basically, you can inject it, and it's foldable, and you can inject it either in the bag, which is the ideal thing, or in the sulcus, but then you have to suture it with Gore-Tex. And so I think the main limitation for us has been the cost. So insurances have been really slow to cover it. So it's a significant tens of thousands out of pocket cost for patients, but they do match it's custom made for the patient. So they do match the color with the other eye. Basically what you have to do is take a picture of their good eye and then print it out. The patient has to sign and say that, it matches. And so, so I think it is, an option for when there is a bag. I think that's the ideal scenario, or a sulcus in completely if it's complete aphakia, like there's no bag or sulcus or anything, then again, you can use Gore-Tex as sutured, but I haven't done it in those cases. And so I think we only have 5 minutes left, so I'm going to stop there in terms of my slides and turn it over to you.
That iris implant's available in the UK as well, but as with everything, you've got to do a course to be able to implant it. That's one thing. And two, it costs a bomb here as well. So a bit like Henry Ford, you can have it in any color as long as it's red. So you can have a cheap one, but it's only one color. I don't know what color it is. And you're not the expensive one. And
then, you know, I think there are some side effects, corneal decompensation, glaucoma, and things like that. So I think picking the right candidate is essential.
And before we wrap up the meeting, one of our colleagues from Saudi Arabia asks if we would like to make any comment on legal aspects related to ocular trauma and its management by ophthalmologists.
Vitreoretinal trauma, you said?
Ocular trauma in general. Is there any way of consenting that you, or are there specific points, for example, in the consenting process that you take care, or like anything regarding legal aspects that we, or how to
Yeah, I think that it's a very important question. I think, you know, a lot of times these eyes are severely traumatized. So you might think that, you know, it's not important, but it certainly is. And like I said, I've been, you know, involved in sort of medical legal review. I think the most important thing is, number one, if you don't have a 24/7 coverage to, if you're on call as an ophthalmologist, to come in and see the patient, because the cases I've been involved in, it's usually missed by the emergency department. And then, you know, then there may be an IOFB found later on and the patient has a bad outcome. So, but I think the counseling process, we do have through our OMIG and things, there are forms in terms of specific counseling for open globe repairs. So I think keeping in mind the ocular trauma score and giving the patient a realistic assessment of the prognosis. We had an IOFB the other day, which the patient came in 2020, but as soon as retina removed the IRB, the IOFB, basically the retina detached. So I think, you know, it's very important. The prognosis and counseling is very important. And there is a book, Ocular Traumatology by Farron Kuhn, which has a whole chapter on this, which I would highly recommend.
Thanks for that advice.
Just last couple of minutes, I thought we'd just get you to critique a video and just your opinion and stuff. I guess first of all to say, Sher and I do quite a bit of trauma, but the problem is usually recording. In the kind of like emergency setting, the last thing people remember is recording. And when it's a bit more less emergency, you can sort of get the videos done nicely. So I guess when we were trying to hunt something down, we couldn't really find anything. So I just sort of got this, what was the only thing I could have. And it's done a while ago, but I thank Yair for editing it. And you can see I had nothing to do with it because it's written MD at the end. Well, it's not very British. The first question I wanted to ask was, can you just talk about symptoms as to whether you would just do the cataract alone, or also do the iridodialysis repair?
Yeah, so I'm looking at, I think you're sitting temporal here, so it does seem to be a nasal, supraronasal iridodialysis. So a lot of times, you know, I'll look at the lid position, but, you know, I think the patient, you know, polychoria is a lot of glare. I think the two major symptoms that they could have. So I'll really try to assess whether they're symptomatic from it, because, you know, it does add this, you know, a significant amount of time to the operation. And then also, I mean, in this case, it looks like the cataract's pretty straightforward in that there's not a lot of, it's not going to be complex. So if you can do the cataract quickly, then I think that would also lean me toward, you know, I'd also probably lean towards doing a few stitches.
Agree with you, Gurj. I just want to do the cataract first, because if the iris starts bleeding because you're faffing around with that at the beginning, that's the end of the case.
Yeah, absolutely. I think the most important thing is getting, you know, a lens in the bag, uncomplicated, and then, you know, secondarily the iris repair.
So I interested the techniques you were using, but I did a scleral flap, but I just wanted you to talk, because as I said, I was sitting temporary and this was sort of nasal. So I didn't get it as big as I would have liked. Can you just comment how big the flap should be to avoid the pupil being sort of, you know, sort of ellipsoid at the end?
Exactly. So in this case, I think you would need at least two loops of suture. So I think I guess you could either make separate flaps or one big flap here. So I would say it would, you know, I agree with making it bigger. And I do think when you start, I like the scleral flap too. So in retrospect with the resident was doing the Hoffman pocket. I mean, that was really challenging. The Hoffman pocket, you can't visualize. So it is nice with the scleral flap to be able to visualize exactly what you're doing here. But you can see here, even with your small flap, I mean, it looks great.
Sher, can you also comment, I think Fasika made a really good point for people doing certain techniques like this about getting it through the limbus and not fish hooking. So if you're not going exactly at the paracentesis, you might catch your suture. Could you just emphasize that, please, for the trainees and stuff?
Just ask that one again. Which bit?
So when you go through the paracentesis, if you don't put the needle straight through the paracentesis and you create another lumen, you fish hook. Can you explain that in a little bit of greater clarity?
Yeah, so that's to do with the entry of the long proline needle at the beginning, which has got to go through a paracentesis, and it's double-ended, so both needles have got to go through that same hole. And so you open it up with some grooved forceps or whatever, but just make sure that you're going through that same hole.
I've seen people do sutured IOLs and they accidentally, the proline catches because it's so sharp that you won't, like, you can catch a little bit of a little bit of corneal tissue. And then when you go to like tie, then you'll realize it's tying to the cornea. Then you got to start over again. So it's really important to make sure that you're free in the paracentesis and that your sharp proline isn't catching some of the stroma.
So question here, retrospectively, I think the flap was too small, or I should have created another flap. In this situation here, would you then put another suture through the iris or leave alone? Or are we dictated by symptoms?
Okay, so you're seeing the patient post-op, or this is at the end of the surgery?
This is pre-COVID, when people were having parties and champagne corks were flying.
Yeah.
Injury happened, and post-COVID, seen once, and then disappeared into the abyss.
Yeah. So so this is you could consider doing a pupilloplasty here to bring it together and make a smaller pupil.
Could you just describe to the audience what symptoms would you be looking for to dictate whether you would do that or not? Yeah,
in this case, they wouldn't have the polychoria because you only have one opening, but they certainly could have some glare, basically glare in this case.
Right, I think,
and it usually works at night.
I think I think that's most of the questions that I wanted to ask based on the children case that I did yesterday and this one. The hyphema study, I think the really important thing, both Sher and I trained in London, we managed a lot of sickle cell patients, and I think don't sit on sickle cell disease because it's disastrous. So I think that was one point I really felt that was really well made and wanted to emphasize. Maria, do we have any other questions from the audience? Imran, is there anything you'd like to add, please?
Yes, thanks, Gurj. I think, great presentation. Just a couple of points. On the issue of sickle, I've certainly had a couple of young black patients who've had very minimal in the way of hyphema, but have had quite high pressures. And one of the things that Volota Sung described this was a technique called gonio aspiration. So when you gonio these patients, they actually have blood in the angle, but you can't see very much hyphema in the eye and the pressure's high. And you've stopped their steroids and the pressure's still high. And I've done this, the last patient I remember was a 15-year-old black guy who had this problem, and we did a gonio aspiration. So what you do is you put an anterior chamber maintainer in, and you use a Charles flute needle, go right near the angle under gonioscopic vision, and you literally clear out the angle of blood cells, and that seems to work very well in some of these patients. So that was one comment. And then a question which is to do with mydriasis. So, you know, I have found with patients with mydriasis, and obviously we see them post-angle closure as well as post-trauma. And often what I'll do is I'll do the cataract, and then I'll see what the symptoms are like. And you'll be surprised that some people with quite bad mydriasis actually don't have any symptoms. So I do sometimes think that it's probably, if they've got a cataract as well, you don't really know what's causing the glare. So I think sometimes it is prudent to think about going in and doing the minimal amount of surgery that's necessary, because what I have found is if you add, and I've had, you know, experience of doing cerclage and pupil repair, what I have found is that sometimes these patients get a lot of inflammation. There's an increased risk of macular edema and other issues. So I think what I've come to sort of realize is that in these patients, do the phaco, see how they are. You can always go back in and do a second surgery at a later stage, because I do feel that some of these eyes they've already got a damaged blood aqueous barrier. When you go in and do all that surgery, the outcome isn't necessarily good, and patients can end up with other problems.
Yeah, absolutely. I agree. Like I agree. You can get inflammation even with the artificial iris corneal decompensation, glaucoma. So unless it's like a pretty straightforward one, I think it's pretty reasonable, especially like you said, the cases of traumatic mydriasis where it's sort of diffuse, those can be really hard to tackle. So I think doing the phaco and usually the patient will be, you know, significantly better just with that.
I really like the goni aspiration. We use a lot of the Charles flute for the secondary IOL, so I think that would be quite a useful tool to use in those hyphema patients. Sher?
I was going to say, fantastic flipping talk. Really good. The only problem you're going to have, Fasika, is you're going to have everyone lining up to do a fellowship in Baltimore. I remember in the military, they used to get sent for, if you wanted to do trauma, you'd go to South Africa. And obviously the UK, we're not as, in trauma speak, we're not as sexy as Baltimore. So if you want
Absolutely, yeah. It's funny because we were talking about, you know, there's no trauma fellowships per se, but it's sort of within each subspecialty. But the thought of starting a trauma fellowship has crossed our mind. So, but thank you, everyone. Appreciated the interaction and all the wonderful questions.
I echo those sentiments, Fasika. Thank you so kindly. We really appreciate it. And thank you, Sher, for such a great and amazing talk from both of you. Really appreciate your efforts. And Maria, as always, thank you so kindly for all the organization and help you've done. Speak for yourself. The UK is very sexy.
Yeah.
Thank you, guys, audience. And hopefully we'll catch you for the next talk. Sher and Fasika, Maria, do you mind just staying on, please? That would be really good. And we'll let the others guys sort of disappear. Thank you very much.
Sounds great. If anyone has any questions, my email is listed there. So thanks very much.